So, go on.
Yeah. So the next talk is about TAVR, what an interventionist needs and does. And Dr. Balakumaran sir will be taking this talk.
Good morning. So just I'm covering on the interventional aspect of TAVR. So TAVR, what the interventionist needs and does. So basically, it is a heart team approach. It constitutes interventional, non-interventional cardiologist and cardiovascular radiologist and cardiothoracic surgeons. So we have a good number of cases in the last almost 3 years. So, and basically before each case, we'll have a heart team discussion with the surgeon, radiologist, and then we'll find out the way. So the transcatheter aortic valve replacement has emerged as an effective treatment alternative. Basically, initially, I think almost 15 years back, it was done only for the ineligible cases who was high risk for surgery. And now, even for intermediate risk, more than 65 years, it is a class 1 and class 2 indication. And even there are trials going on even for the low risk patients also. For the TAVR, imaging is very, very important. It started with the echo to diagnose whether it is a severe aortic stenosis, whether it is a low gradient aortic stenosis. So generally, when we started this TAVR, most of the time we misses out the low gradient aortic stenosis. We thought a patient have LV dysfunction, we have to treat medically, we leave it. Because the gradient what we'll get in the echo, generally it will be around moderate. So we thought we will leave it for some time. So by the time we will wait for another 2 to 3 years, the gradient will remain the same, LV will go down actually. So now, I think after the 2014 guidelines, AHI guidelines, these everything scenarios have changed. So they came with the guidelines of low gradient aortic stenosis, and after that we see there are significant number of TAVIs in the last 10 years. Mainly, almost I feel it is around 30 to 40% is for low gradient aortic stenosis. So basically, echo plays the main role, and CT has a role. I think we all discussed, and the CT wise calcium score and the planimetry plays an important role for diagnosing the low gradient aortic stenosis. And definitely echo wise a continuity area where most of the time we miss us out. Now I think we are doing continuity area, and then we'll go out for the CT, which is of immense help. So this transcatheter aortic intervention is underpinned by array of imaging techniques designed not only to select an appropriate size implant, but also to identify potential obstacles, whether patient will develop complications, and we have to keep in mind, okay, patient is having calcium, patient is having elevated calcium, this patient will develop a paravalvular leak, so that some patients think is that there are calcified raphe will be there. If you are post-dilating more, the patient may develop annular rupture. So all we have to keep in the mind, basically with the radiologist in the background. So otherwise, very, very difficult for us to go ahead. So accurate sizing is very important. Now there are two available valves. One is a self-expandable valve, another is a balloon expandable valve. So each has its own pros and cons. So there are inherent technical issues with the 2D echo, and obviously TE has a major role, followed by a CT assessment. So basically it is a heart team approach, cardiologist, cardiovascular radiologist, and cardiothoracic surgeons. So role of echo, so what is that? Severity of aortic stenosis, mild, moderate, or severe. If it is severe, it is a normal, it's high gradient, what is general normal aortic stenosis, or it's a low gradient aortic stenosis. So for that we have to calculate the EF and continuity area. By continuity area, if it is less than 1, it is considered as severe, and assist in the TAVR valve sizing. So preliminary investigation to diagnose and categorize aortic stenosis, especially low gradient. TTE assess the patient's suitability for TAVI, that is whether how is the aortic valve complex, how about the calcium, morphology, that is whether it's a tricuspid or a bicuspid. Basically, we Southeast Asians, if you see that almost like 40% as per data are a bicuspid aortic valves, but what we are doing TAVI, if you see, almost 60% are bicuspid aortic valves. Generally, bicuspid aortic valves is off-label aortic stenosis is off-label indication for TAVR, but by most of the valves, what we are seeing is all bicuspid aortic valves. Because there are bicuspid valves, there are chances of any complications also. I'll show you. So also echo used to assess the degree of AR and other valvular diseases, because if there is no AR, we have to predilate the valve. If it is a more than mild AR, I think it's good enough. There is some flow is there, so we can go for a direct deployment of the valve. And there's a LV EF and the diastole dysfunction, and also the right-sided pressures, that will see the prognosis. So what are the views for aortic annulus for TTE and TEE? Only for, that is a transthoracic view, it is a parasternal long axis, and for TEE, it is a mid-esophageal long axis view. That is for the aortic annulus, but most of the times we depend on CT 3-Mencio only. This is a basic thing, because most of the times the annulus by TTE, we will overestimate this. So, and during the procedure, what is the role of echo is to assess the MR, because if there is a severity of MR, it may change dramatically during the procedure, because sometimes we are keeping the wire will entangle the cardia and all, and they may develop papillary muscle rupture. So the baseline MR has to be calculated. That's a mitral regurgitation has to be calculated, and LV dysfunction and severe AR, SAM, everything. The SAM also plays a very important role, because patients who have the basal septal hypertrophy, sometimes if you deploy the valve, it may pop out actually. So all these things we keep in mind by CT. CT is a major role. So initially we'll do the echo, and then we'll correlate to the CT also. So, and during the wire insertion, it is often difficult to pass a gateway retrogradely through the narrow aortic wall. So echo plays a role, and mainly TEE. So TE can easily visualize the position of the stiff wire, where it is coiled, where it is in the apex or not. Fluoro-wise also we can see, and echo also give a good view. So these wire injury or entanglement within the mitral apparatus may cause MR. TE is very important. So there are strengths and weakness of TTE and TE. Now most of the cases we do with TE only. Even with the conscious sedation, we make sure, because the procedure will be around 30 to 45 minutes, we'll make sure that TE will be useful. Because transthoracic, okay, for TE will be more invasive for the conscious patients. So both has its own benefits and risks. So TTE, no sedation is required. TE, there is a need for general anesthesia, but we can monitor with the conscious sedation. And imaging TTE advantage, standard views, and TE we can get the high resolution. So that's the thing. So Brazilian registry, if you see, they compared the transthoracic and TE. The TE definitely has an edge. There is a mortality benefit with the TE. So just I show some views. So there's a TAVR wall. The first you can see that it's a echocardiographic. The circular, it is the optimal deployment of the TAVR, and there's a Kovai. So it's a suboptimal deployment. There are chances of paravalvular leak. So you can see here there's a zero deployment of the TAVR wall. Exactly it is placed. So here if you can see that the TAVR wall is a core wall. It is pushed inside the LEOT. So there are chances of AR and chances of conduction block also, more of a conduction block. So these are things we need before TAVR. Generally, if it is more than 4, P gradient more than 64, mean gradient more than 40, it is called a severe aortic stenosis. After TAVR, we need a gradient in the single digit, and Vmax should be less than 1.4 or 1.5. So CT imaging, going to CT imaging. So all structural interventions need a 3D understanding of cardiac anatomy. It's non-invasive, and it's an important modality for choice of planning and to prevent the complications. And we can, most of the time, we always will do the post follow-up CT also, because later patient coming with any complication of coronary obstruction, it is easy for us, because it is very aligned or not, we can intervene based on that. So we need an imaging protocol, I think already has been discussed, and confirmation of diagnosis. Yeah, CT will give an extra added advantage, where it's a low gradient aortic stenosis, and based on the calcium score and planimetry. And again VAV for the virtual distance for the coronaries, it plays an important role on follow-up imaging also. So I think the calcium score already we discussed. For males it's more than 2000, and females more than 1300. It indicates a severe aortic stenosis. What are the things we need in the CT? Valve morphology, calcium distribution, aortic annular dimension, and presence of annular or subannular calcification, left main height, RCA height, and S2J, and optimal coplanar views. And there are multiple views what we are discussing, coplanar and commissural alignment and all. So for a peripheral vasculature, there is a ascending aorta pathology, any thrombus is there, any calcium is there, because calcium is very difficult to track our wall. And this is pathologies of the arch, that is any coarctation is there, pseudo-coarctation is there, and iliofemoral vasculature and the common femoral artery, because generally most of the with the delivery system is quite tracky, and if it is more than 5.5 millimeter, most of the times we'll track the wall actually. even with the balloon expandable and all, because now it's available between 12 to 14 French also. And if it is femoral access size is less, there we have to assess for the other approaches. That is most commonly we go for the transcarotid, transcaval, very rare actually. We don't have any experience in transcaval, so we have mostly are doing transfemoral and transcarotid. So what is the wall morphology? There's a tricuspid aortic wall. Tricuspid aortic wall, good thing is that when we deploy the wall, it will it will be optimally, it will get placed around the annulus. It will be a circular. Problem is with the bicuspid aortic wall, and always with the type 1 calcified raphe is a very difficult to place the wall, and you have to be very careful because the calcified raphe is so stiff that we can't, the wall won't get expanded in that side. So we have to see if it is a calcified raphe on the left side and it's the right coronary height is lesser on the right side, you have to be very careful, and we have to protect the right coronary because the wall won't get expanded wherever there is a calcified raphe. So what is the problem with the bicuspid aortic valve is most of the times there will be undersizing, underexpansion, and there are chances of paravalvular regurgitation is more commonly with the bicuspid aortic valve, and also there is a calcific raphe and excessive leaflet calcification also. And generally they have a aortopathy, so there are more chance of aortic root rupture also. So you have to be very careful post dilatation and thing. Always very careful. And for bicuspid aortic valves, usually the perimeter derived approach will be used to, like generally what routinely used for the TAVR, it will overestimate. So area derived perimeter will be the very optimal for assessment of the bicuspid aortic valve. So why challenging is larger annulus generally with the bicuspid aortic valve and severe and asymmetric leaflet calcification, presence of the calcific raphe and concomitant aortopathy. So this calcium distribution is very important, whether it is symmetrical calcium distribution or asymmetrical calcium distribution. Symmetric at least we can accept, so that valve will get it will get optimized for along the annulus. But if asymmetric, again it may push towards the one side, and there are chances of again paravalvular leak and coronary obstructions also. And second thing already I mentioned is septal hypertrophy. So whenever there is a septal hypertrophy, there are more chances of valve getting bulged out, popped out actually. So be very careful with the septal hypertrophy, and most commonly if there is septal hypertrophy is there, we will go with the balloon expandable valve than with the self-expandable valve. And these are the things, the classification of say annular and subannular and LEOT calcification. This is the mild and moderate calcification, and there is a severe, so it is single or multiple nodular calcification protruding into the annular lumen and extending the LVOT. Always there will be a chance of the paravalvular leak, and we have to accept that. If it's a mild paravalvular leak, we have to accept that. So again, for aortic root dimensions, we need a very important is left coronary height and right coronary height. If the more coronary risk will be there if the height is less than 10 millimeter, and based on the other parameters like STJ size and leaflet thickening and leaflet size, whether with the coronary protection is needed or not, we have to see. So these left coronary height and right coronary height is same thing. I think is obtained measuring with the caliper perpendicularly from the annular plane, all universally accepted as 3 Mencio. Again STJ height. So basically see this also very important. So after measuring the coronary height, if you see it's around 10 millimeter, coronary right coronary is on 10 millimeter, this we have to see. Generally if you see the frame height, if you see 47% will have this frame will be there. This 53% will have the like it's a open cell. So generally if the coronaries come in this area, okay, we are saved. But if the coronary height is less, maybe 5 millimeter, 6 millimeter, it will get stuck in this frame height, then we are always you need to protect the coronary. See, these all is useful. If it is we are taking the wall around 20.5 or 21, 23, that's okay. Even coronary height is 8, we can manage. But if it is a valve size is around maybe like 27 or 29, but if the coronary height is even 10 millimeter, again the coronary is also at the risk. So this all we have to correlate with the coronary height, and again virtual we have to place this valve and see whether the coronary is getting involved or not. And another thing is that now we always used to see the coplanar view where the 3 cusps are arranged in the straight line. Now there is a cuspal overlap. There is a overlapping of the right coronary cusp and left coronary cusp, mostly with the self-expandable. This has the important role, and most of the times our radiologists will give whether it is a what is the cuspal overlap, what is the view, and then we will correlate by doing the procedure, and these are immense cell mainly with the self-expandable. Balloon expandable, Both are same, whether it's a coplanar or cuspal overlap, this is okay. So again, commissural alignment during TAVR should be achieved to facilitate the future coronary access. We can do now, but future, if there is commissural misalignment is there, always a patient is coming with the MI, it is very difficult to hook the coronaries. So there are advantages now, so that we can, each delivery system has a label there, so that we can align. Okay, you have to, if a core valve is there, there is a 3 o'clock, there is a position that cannula will come, so that we have to go inside and then we have to deploy without changing the delivery system direction. Same with the Sapien and MyValve also. They have the emblem in that E and then MyValve, so that we have to avoid the commissural misalignment, because the future coronary risk will be a problem. So commissural alignment increases the feasibility of selective coronary angiography after TAVR, mainly with the supraannular devices. So these are the things. So 3 o'clock position, there will be a flush port will be there, so that we can avoid the commissural misalignment. So this is the commissural alignment acceptable if it is 0 to 15 and 15 to 30 also, but if it is 45 to 60, future coronary will be a problem. So this is the thing, commissurally aligned here with the coronaries, so not a problem for a future coronary. Here if you see here, the commissural alignment is along the coronaries. So very difficult to intubate the coronaries, the patient comes with MI. So always this CT will give a proper picture. So these are the thing, again 0 to 15, 15 to 30, this is acceptable up to this. Moderate and severe commissural misalignment, difficult. So next thing is the vascular access. Yeah, whether it is any pathologies of ascending aorta, or how is the diameter, whether it is more than 5.56 millimeter. If it is less than 5, we have to see for the other access, whether it is a transcarotid or subclavian access. So again, common femoral artery, any calcium is there. For a puncturing, any anterior calcium is there, posterior calcium is there. Because if it is anterior calcium is there, proglide is a difficult one, so that we have to do a open access. You have to expose and then we have to do it. And report findings in regards to the level of femoral lead, whether it's upper third, center or lower third, and where is the femoral bifurcation. Most of the times we do with the fluoro and ultrasound guided now. And the subclavian artery, again the second choice, there is a minimal diameter, again there is a calcification, and again it's a carotid also. So these are the things we see here. There's a calcium. So everywhere, almost like a porcelain aorta. The problem with this is very difficult to track the wall. So all along the aorta there is a calcium. So this is generally most of the times, if we see the patient, if we are doing the patient more than 75 years of age, we have this type of calcium. So alternative access, yeah, most commonly transcarotid, because it is simpler and easily trackable also. The only thing is that past history of CVA, and then we have to see any vertebral artery occlusion, and contralateral carotid also is okay. So next is a VIV. So generally, like most of the time, now we are getting is a valve-in-valve only, because a bioprosthetic valve is getting degenerated more than 10 years, and what our volume also, if we see, around 30 to 40% of the valve-in-valve cases only, and most of the times we can say, okay, what is the type of the valve? It is a perimount or whatever thing, magna. And if it is very difficult, these fluoro findings will give the like idea that which valve they are used, and based on that we can use. If it is previously it is a stented valves, it's okay, not a problem. Just 5 minutes, just going into that. So these are the things. So if it is a coronary involvement is there, this is a basilica. Is a bioprosthetic or native aortic scallop, the intentional laceration to prevent the iatrogenic coronary artery obstruction. So this is the thing you do actually in the valve-in-valve. If there is a risk of any coronary obstruction, we'll perforate the aortic cusp. We'll snare it from the LVOT and then tear the valve. So there is no risk of coronary obstructions also. So again, the basilica CT imaging plays an important role. So that's the thing, VTC is very important. So all the valve-in cases, we will keep the valve virtually and measure the distance between the virtual valve and coronary distance. If it is more than 4 millimeter, no need of any basilica or anything, coronary protection. If it is less than 4 millimeter, either on right side or left side, definitely we need the coronary protection or we need a basilica. So again, post-procedure, paravalvular regurgitation, we have to see. You can see here, after the deployment of the valve, there is a significant paravalve agitation. There's no other way. We have to close with the plug. So again, prosthetic endocarditis, patient coming with a fever after TAVR, either month of 2 months later. We can see here there is a hypertenuated and the vegetation is growing, and we need to start IV antibiotics after the cultures. Again, leaflet thrombosis. We see that over the follow-up, the valve gradient is increasing, so we can get a CT done, and there is a hypertenuated. Again, there is a leaflet thrombosis. The advantage of TAVR is avoiding the anticoagulants, but if there is a leaflet thrombosis, anything, we have to keep the patient on anticoagulants and see whether the gradient is coming down. If there is gradient is not coming down, then we have to think of alternative. There is a valve involved or it's open. So again, there is a classification for that and for this. So what are things necessary? Paravalvularly and conduction disturbances, coronary obstruction, this aortic trauma, all of these are the predictors, such as LEOT calcium and low coronary height, less than 10 millimeter, narrow sinus of valsalva. And post-procedural, these are all we have to see: paravalvularly, valve thrombosis, and structural deterioration. So our experience, this I'll see 2-3 cases, I'll show. So we need aortic annulus, LEOT diameter, coronary height, RCA, LCA height, everything. So this is the case with pseudocoarctation. You can see here. Problem is that very difficult to track the valve here. So we need to take extra protection for this. So almost like a coarctation. This is a gentleman, 72-year-old gentleman. So problem again, this patient also had you can see here annular calcium extending into LVOT. So took a self-expandable valve, and with the double coronary protection, you can see that even the thermo is not crossing also. Very difficult to track the pseudocoarctation here. It is bending there and going. So tracked it. So we have to take the two stiff. You have to keep the two stiff wires. So one in the pigtail and another stiff wire, and then we have to track the valve. So valve deployment is done. So again, another gentleman with the low left coronary height. You see here it is a 9 millimeter. This I think is an elderly female, obese, 120 kilo female. Problem also is that there's a LCC length is 12 millimeter. Very high chance of coronary obstruction. So as I inflated the balloon and see whether the coronary risk will be there. If coronaries are flowing, so I protected the coronaries, left coronary with the gate. You can see here is a left coronary is protected and deploying the valve here. The coronary is well flowing, and he's in almost 7 months follow-up doing well. So this is another guy with another female with a low RCA height, 8.5 millimeter. She is the double wall actually involving a mitral MAC also. So planning for a MAC TAVR in MAC maybe next month. Almost post TAVR now, 1 year follow-up now. Again, this female also, if you see here, the right coronary height is less, 9 millimeter. So I have to protect the right coronary here and then deploy the valve. Yeah, flowing well. You can see the septal bulge, how the valve is pushing out. Yeah, pushed out. So I have to deploy another valving valve. So again, there is one annular rupture, one case. I will show you. You have to close with a coil there. That is some CMC. Again, VTC distance is very important. So this is a basilica animation I showed you. So we have to perforate the cusp and then snare it, and then we have to do the electrocautery. Again, non-femoral approach. 3 months back it is a transcarotid valving valve. She came with a low-grade aortic stenosis, severe on dialysis, renal dysfunction. Now post-procedure, she's on follow-up now, walking around, create is normal. We deploy. This I'll show you. I'll rush up through. The SEVAR did. Actually, our TAVR journey started with this case actually. Before we used to call a proctors almost 2 years back. So now this patient came with a 16-year-old gentleman. He's a farmer by occupation. He was working daily in his farm where he cultivates a sugarcane. Here in 2011, he had aortic valve replacement with the Perimount pericardial valve. So he was on regular checkup. He had a COVID 3 months back and was treated. On the day of event, he was working in the field. He was lifting heavy weight. Suddenly, he had a giddiness and breathlessness. And outside that, this was the, I'll show you. ECG was such a diffuse ST depression. They loaded. They thought of ACS and referred to us. He came at KMCH 2 hours after the onset of symptoms. Differential diagnosis and emergency was acute coronary syndrome. Aortic dissection, generally post AV or aortic dissection is very, very less because the dissection won't cross the suture line. And there are aortic leaflet rupture. Yeah, it's a definite aortic leaflet rupture in emergency. So you need a TE also. So never heard sudden rupture of the bioprosthetic wall causing acute severe AR. TE was done immediately to confirm that, and CT was done. It was around 7 o'clock around. So CT was showing VTC distance was adequate. It's around 6 millimeter on right side, and left side is also around more than 7 millimeter. So not a issue. The CT we did here. No aortic dissection. Coronary also was okay. So around 11 o'clock we did this case. The valve from Coimbatore we had to get the valve from Chennai. So by the time they started from Chennai, we shifted the patient to cath lab and got everything ready, access everything ready. Because waiting next day he will collapse. Already like the huge heart deployed. So perfect. He is almost now almost nearing to January we did 2022, nearing 2 years follow-up. This was the first case extubated next day, discharged after 4 days. This is the first case reported case of valve in valve tower for severe aortic regurgitation due to sudden rupture of valve leaflet in a bioprosthetic valve induced by stress. So these was the baseline. Then we started doing ourselves, no proctor anything. So in good number of cases. Thank you. Thanks for listening.
Thank you, Dr. Bala. That was absolutely incredible. I loved your cases. I loved the fact that you had absolutely zero aortic regurgitation at the end of your last case. And not only that, even the best basilica that you're doing, you're probably one of the few people who are doing it in India. And did you manage to salvage the the annular rupture?
No, aortic rupture is not our case. As a courtesy, I put CMC. So I want to show that case. I have.
Okay, all right. I was just wondering.
Saved actually.
Yeah.
Colleagues actually saved.
Cool, great. Okay, that was a great talk. And I think the fact that we're going to, the TAVRs are now going into the low risk category, it's very important to understand that in the future we're going to need, coronary interventions. So to take all the commercial alignments and all is really, really important at this age. So any questions from the audience?
No, still covered. Yeah. So most of the times for TAVR, government insurance won't cover. Only corporate insurance will cover. Government insurance will give the cover. No.
No, they all give. Everybody gets. Everybody is covered.
Then in India we can't do any TAVR.
80% is bicuspid. Everybody is functional bicuspid. Everybody is a functional bicuspid in India. Who's not a bicuspid? Everybody is bicuspid only. Hai na? It's like somewhere or the other there's some partial like fusion. There are hardly anybody who's...
We also face the same. Yeah, I got the request that please change it to...
Oh, as a bicuspid, they're taking it as a congenital bicuspid. Then you have to write acquired bicuspid.
Just don't write bicuspid or just omit that line.
You can mention as a functional bicuspid, I think.
Yeah, say it as a functional bicuspid because then you've got commissural thickening calcification. Okay, then don't say. Huh.
So generally, the less number of cases in our center, maybe the southern part is problem with the insurance. Only the tertiary cash, Delhi and Mumbai, they get corporate insurance are giving almost like 15 lakhs, 20 lakhs.
No. I'm with Dr. Seth. I have like 5 TAVRs a day. Yeah, they're covered by insurance, TPAs, this, that, lots of things. Even government.
Dr. Thomas, thanks for the excellent talk. What proportion of patients in India with aortic stenosis have degenerative cause and what proportion have rheumatic heart disease as the cause?
Aortic stenosis, the aortic stenosis most commonly we are seeing is the degenerative aortic valve.
Okay.
I think the rheumatic etiology now has come down drastically. I think even now, maybe at our tier 2 city, the rheumatic patients are seeing very, very less. Most commonly we are seeing degenerative aortic valve, and generally rheumatic aortic stenosis are relative contraindication for TAVR.
Right, yeah, that's what my next question, okay.
How much Hal and Ham are you seeing? How much of this hypertenuated leaflet thickening and movement are you seeing, abnormalities?
Leaflet thrombosis?
Yeah.
Very rare.
Very rare. And are you using any neuroprotection devices?
Ma'am, actually problem is that our side is the cost, ma'am. Thing is that if you are using the neuroprotection, it will cost, it will add another 3 to 4 lakhs actually. It's not a problem in Chennai or maybe in Delhi, but in Coimbatore,
we're using,
Coimbatore is difficult, we are not using actually.
Okay. We're using the neuroprotection.
Which is the commonest valve you are using for TAVR?
Balloon expandable, and mostly it's the Indian valve, my valve. You are more experienced with the my valve.
Thank you.
The thing is, the MyValve has become
Excellent work.
so
Thank
much
you.
cheaper.
The problem is that cheaper. That's
yeah, even Dr. Makar and all from the US are now saying, when are you coming to the US kind of a thing. So I think this Make in India has really done very well. But great. Thank you so much. Thanks, Dr. Bala, for an excellent talk. It's great to have a cardiologist here.